Hi everyone, and in this video I'll be discussing another topic, skeletal muscle relaxant. Now, why should we relax the skeletal muscles? Now, we know that we can voluntarily contract a muscle. Imagine that you are running a race and suddenly your muscle catched. Then you have to relax the muscle. Otherwise, you will have pain. Suppose you are giving a general anesthesia. Now, anesthetics are not completely producing muscle relaxation. So, we have to give muscle relaxation as a separate drug. So during general anesthesia also we have to give this muscle relaxants. So let us understand what are the drugs used as skeletal muscle relaxants. Let us start. To understand this topic, I have taken three patients. A patient had muscle spasm while running. And second patient, he needs to be intubated. So when you are intubating, the muscles around the neck, they should be relaxed. So intubation is easier. Patients needs adequate muscle relaxation during anesthesia that I told you. During anesthesia, we have to relax the muscles. Now, how do we do that? Let us understand. For that, we need to understand a bit of physiology. So, the junction where we are dealing is what we mean by the neuromuscular junction. So, let me write the neuromuscular junction. This is the nerve, and let me write the muscle here. So, this is the muscle. So you know that the junction between the nerve and muscle is neuromuscular junction. Now, who is the neurotransmitter coming in the neuromuscular junction? We know that it is the acetylcholine which is stored when there is entry of sodium, there is entry of calcium, and the calcium will tell the acetylcholine to get released. The vesicle will fuse and the acetylcholine gets released. The acetylcholine which is released acts on the receptor, and that is the NM receptor, the NM receptors. Now, NM receptors are ion channel receptors, so they allow the entry of the ion sodium. So the sodium ion enters inside. Now, along with sodium, who enters inside is the calcium. Now, sodium and calcium are positive ions, they enter the muscle. In the muscle, there is a reticulum called sarcoplasmic reticulum, and there is a receptor which releases calcium from there also. And the receptor is called ryanodine receptor 1, and that is responsible for calcium release. So, the calcium which has come, they are responsible for the muscle contraction, skeletal muscle contraction. So this is the normal physiology. Normal physiology. Fine. Now I want you to think and tell me, where should I block so that the muscle will not contract, instead it relaxes? Take a guess. Now the first one which we have studied in autonomic nervous system, you can stop the release of acetylcholine. There is a drug which can decrease acetylcholine release. Yes, any guesses? What is the drug which decreases acetylcholine release? Yes, you are right. The name is botulinum toxin. So we have studied about botulinum toxin in ANS pharmacology. Just a recap. It is used for cosmetics. We use it locally for wrinkles and glabellar lines, blepharospasm, any muscle spasms like cervical spasm or Achilles cardiac. So that is the botulinum toxin which you have discussed already. Then what we can do is we can use a drug called succinylcholine. The name is succinylcholine. Now succinylcholine sounds like acetylcholine. So this will also act on NM receptor and repeatedly stimulates it. Now what happens if you repeatedly stimulate a receptor? They undergo desensitization. But here, these nicotinic receptors are special. They undergo rapid. So rapid desensitization and the receptors will not work. So what happens if receptors are not working? The muscle will relax. So succinylcholine is also called as depolarizing. It is also called as depolarizing skeletal muscle relaxant. That means initially it will allow the entry of sodium and calcium. Later it will desense the receptor, and that's the reason it is called depolarizing. It acts like acetylcholine only. It acts like acetylcholine only. Another strategy what we can do is we can block the NM receptor. Now the blocker of NM receptor example I will give you, D-tuberculin. Now what happens if I use D-tuberculin? Acetylcholine cannot bind because it's already blocked by D-tuberculin. So the agonist for this place is acetylcholine. The antagonist for this place is D-tuberculin. Now the question here is D-tuberculin stimulating the receptor? No, it is blocking the receptor. It is blocking the receptor. How it is blocking? Competitively. So it is competing with acetylcholine to block. So it is also called as competitive blocker. So these are competitive skeletal muscle relaxant. Or can I call them as non-depolarizing? You compare succinylcholine, it was stimulating the receptor and depolarizing the cell, but here it is not. So these are competitive, also called as non-depolarizing skeletal muscle relaxant. So the example is D-tuberculin. Question here is, suppose I have given D-tuberculin to a patient during anesthesia. So I want to reverse it back. How do I do it? You know the general pharma. Competitive antagonism means antagonist, agonist bind to the same site. And can we overcome the antagonism? Yes. How? By increasing the agonist concentration. But you know that acetylcholine is not used therapeutically. Now how do I increase the level of acetylcholine? You know that acetylcholine is broken down by the enzyme cholinesterase. So if I inhibit this enzyme, the acetylcholine level increases and this will kick the D-tuberculin out. This will kick it out. So what is the drug which inhibits that? To reverse this, we use the anticholinesterase. What are the name of that? They are neostigmine and one more is pyridostigmine. So we can use neostigmine and pyridostigmine to reverse this. But what is the story of succinylcholine, sir? Succinylcholine, the story is it is depolarizing and you cannot use neostigmine or pyridostigmine here. The reason is if you are using them, neostigmine, pyridostigmine, what happens? They increase the acetylcholine. Acetylcholine will also repeatedly stimulate the muscle and it will also cause depolarizing skeletal muscle relaxation. So they are not useful. And what is the difference between succinylcholine and acetylcholine is acetylcholine is metabolized by mainly by cholinesterase. Yes or no? And if you give IV acetylcholine, it is metabolized by pseudocholinesterase. So when we give succinylcholine, when the succinylcholine is given in the blood vessel, we have a special enzyme to metabolize that, and that is called pseudocholinesterase. So that is the one which metabolizes it. Pseudocholinesterase is also called by one more name, butyrylcholinesterase. So that's the reason succinylcholine is very, very short acting skeletal muscle relaxant, because it is metabolized by pseudocholinesterase. And in general, any drug metabolized by that are usually shorter acting. So we understood the differences, the depolarizing skeletal muscle relaxant and non-depolarizing skeletal muscle relaxants. And you can reverse it by neostigmine, pyridostigmine, that is D-tuberculin, but you cannot reverse succinylcholine. So we have three targets. Number one, the botulinum toxin. Number two, the succinylcholine. Number three, D-tuberculin group of drugs. Number four, we have a drug which can block the rhinoid receptor, which can directly relax the muscle. So if you block this receptor, calcium is not released. If calcium is not released, then the muscle will relax. The fourth category, the drug is called dantrolene sodium. So it is called as dantrolene sodium. So guys, these drugs which act on neuromuscular junction, whatever they act on neuromuscular junction, they are called as peripheral skeletal muscle relaxant. So those who act at the neuromuscular junction are peripheral skeletal muscle relaxant. Let me tell you again: botulinum toxin, then succinylcholine, D-tuberculin, and dantrolene. They are called as peripheral skeletal muscle relaxant. Now the problem in peripheral skeletal muscle relaxant is there is decrease in tone of the muscle. So muscle tone is decreased. Very good. There is decrease in voluntary power of muscle. Voluntary power of muscle. That means if you give a succinylcholine or D-tuberculin someone, the muscles are paralyzed. He cannot lift the hand. Even if you tell him, he cannot lift. The problem is if you give these drugs, the patient will have respiratory depression. The respiratory muscles are also paralyzed. That means these drugs should be given in intensive care units. These are used in anesthesia practice. You cannot give them routinely to the patient and send him home. No, not possible. So that is about the peripheral skeletal muscle relaxant. I was talking about one more patient who was running and suddenly got a muscle catch. Now, why the muscle catches? To prevent a further injuries, there is something called polysynaptic reflex. So the receptors from the joint or the muscle, they activate the CNS and give a command to CNS telling that stop this further injury. So there is a polysynaptic reflex which comes at a neuromuscular junction. So let me take, this is the CNS, and CNS has polysynaptic reflexes which will come and inhibit this neuromuscular junction. Now the drugs which increase this effect, so when the CNS gets activated, the muscles will undergo spasm. So the muscles will undergo spasm to prevent a further injury. So the muscles will undergo spasm. So how to overcome these spasms? How to overcome this? Then what you have to do is suppress the CNS. Suppress the CNS. Now, how do you suppress the CNS? There are drugs. Now, these drugs which act on the CNS are called as central skeletal muscle relaxant. So, suppose I am running and I got a muscle catch. I should be given central skeletal muscle relaxant. The reason is when there is a reflex pathway, the tone of the muscles are increased. That's why suddenly I turned and my neck caught. So the tone is increased. So these drugs decrease the tone of muscle. Now, do they affect the voluntary power? Now, after I give the drug, can the patient move his hands, legs? Yes. No effect on voluntary power. No effect on voluntary power. And the most common adverse effect what we see is sedation. Why sedation with these drugs? Obviously, you are suppressing the CNS. So basically, now we have centrally acting skeletal muscle relaxant and peripherally acting skeletal muscle relaxant. The difference is same. No? What are the differences? Can you repeat? In central, the site of action is in CNS. In peripheral, the site of action is neuromuscular junction. In peripheral, there is decrease in tone as well as voluntary power. You have to give it in ICU or anesthetic practice. Centrally acting, you can give it at home also, no problem. They only decrease the tone. There is no loss of voluntary power. And usually they are used for muscle spasms, and the main problem is sedation. So once we understand the differences, let us start our journey. So the first thing what I am going to discuss is the central one. Central skeletal muscle relaxant, SKMR. In that, What is the mechanism? They inhibit polysynaptic reflex. Yes, and they can cause CNS depression. And because of that, patient may complain of sedation, one of the drawback of the drug. Okay, sir. What are the drugs we have in this category? The drugs are the alpha 2 agonist. We have discussed this in ANS. Alpha 2 or GA coupled receptor, they are inhibitory. The name is called tizanidine. The name is tizanidine. Second, our own GABA receptors. So in that we have GABA B. So we have GABA B agonist. The name is called baclofen. So baclofen, apart from this muscle relaxation, it's also used for hiccups. So hiccups, there it is used. So it is also used for treating hiccups. Then another, the drugs which increase GABA activity, particularly the GABA A activity. Yes, you know these drugs. Come on. They are nothing but benzodiazepine, particularly the drug diazepam is commonly used because they have muscle relaxant property. Then we have the next group of drug. They also increase the activity of GABA in the brain. And the name is called, it is called thiocolchicoside. It is called thiocolchicoside. Thiocolchicoside, it is going to increase the GABA in the brain. Then the other aspect what we have is mefenacin derivatives. They are called mefenacin derivatives. So in that we have a drug called cari. The name is called carisoprodol. And one more is called chlorzoxazone. So we have carisoprodol and chlorzoxazone, which are used as muscle relaxant. Okay, so these are central acting. Please remember they only decrease the tone. And which patient do you give it? I told you a patient running and has muscle spasm, there you can use it. So once I know that, where do you use it? Uses. So where do we use them commonly in our practice? Now they are used, what I was discussing just now, they are used in acute muscle spasm. So muscle spasms, they are used, particularly used by the orthopedicians. It is used in the backache, to relieve the backache, or torticollis, in the management of torticollis. Suppose patient is having anxiety and tension. When they have anxiety and tension, their muscle will be contracting. So we use it in managing anxiety and tension. And then spastic neurological condition. What are the spastic neurological conditions? You can see the cerebral palsy. Cerebral palsy, and one more condition where they will see the spasticity is the multiple sclerosis. Multiple sclerosis, there we want to relax it. Now we have to relax the muscle when you are giving a shock electroconvulsive therapy. Suppose the patient has tetanus, so there we have to relax it. Or if you are doing a small orthopedic manipulation, then we can relax these things. So these are the important things. Just remember they are used for relieving the muscle spasm. That's it. That are centrally acting skeletal muscle relaxant. Moving on to the next concept, we have the peripheral skeletal muscle relaxant. Now in peripheral, the junction I told you, they act at neuromuscular junction mainly. In peripheral, we have two important variants. So that is the direct acting and the indirect acting. Now, what is the meaning of direct acting? The meaning is it directly acts on the muscle. Indirect acting means they don't act on the muscle, they act on the receptor, that is neuromuscular junction. The directly acting skeletal muscle relaxant, the name is called dantrolene, sodium. And one more outdated drug, quinidine. So quinidine is an antiarrhythmic drug and it is also considered as a direct skeletal muscle relaxant. Okay, we'll come to the indirect later. First of all, let us discuss the story of dantrolene. So let us importance of dantrolene sodium. Now let me write here. This is the muscle. This is the skeletal muscle cell. Right. So here what happens? There is the rhinodine receptor. So sarcoplasmic reticulum, and from this the calcium is released. And the receptor is called rhinodine receptor 1. I write a full form here. It is called rhinodine receptor 1. Now, won't it affect the heart, sir? No. In the heart, the receptor is rhinodine receptor 2. So that's why rhinodine receptors in the heart are not affected. So only the skeletal muscles are affected. Now, when I use these drugs, it inhibits the receptor. So dantrolene acts by this mechanism. Now, where do I use this drug? It is a drug of choice for two conditions. Dantrolene is a drug of choice for two important conditions. One is neuroleptic malignant syndrome. Neuroleptic malignant syndrome. Now, in this condition, what happens is the D2 receptors are blocked, and this is seen with typical antipsychotics mainly. So, when we are using typical antipsychotics, particularly the haloperidol is known to produce this problem. Okay, so dantrolene is a drug of choice for neuroleptic malignant syndrome. One more condition it is drug of choice is a condition called hyperthermia. So what is the problem in malignant hyperthermia? In certain individuals, there is defective rhinodine receptor, that means they are hyperactive. They start releasing more and more calcium. Who will release that more and more calcium is whenever the anesthetics are given. For example, inhaled anesthetic like halothane, or whenever the muscle relaxant like succinylcholine is given. So succinylcholine and inhaled anesthetics like halothane, if you are giving in these genetic individuals, they have this abnormal rhinodine receptor. As soon as you give them, they start triggering activating rhinodine receptor and calcium gets released. The muscle rigidity increases, muscle contraction increases, temperature goes up. So for them also the drug of choice is dantrolene sodium. So it's a drug of choice for two conditions: neuroleptic malignant syndrome seen with typical antipsychotics, and also malignant hyperthermia, a pharmacogenetic condition. In certain people, the rhinodine receptors are hyperactive and the muscle rigidity and high temperature is seen. And particularly when you are using succinylcholine and inhaled anesthetics, they are also drug of choices, dantrolene sodium. Yeah. So that is about the direct acting skeletal muscle relaxant. Moving on to the indirect acting. Indirect acting. So in indirect acting, there are two important. One is the depolarizing skeletal muscle relaxant. It is called the depolarizing skeletal muscle relaxant. The major drug here is succinylcholine. It sounds like acetylcholine. The main drug is succinylcholine, and one more, the older drug is decamethonium. Decamethonium. Okay. Sir, what should I remember? Mainly remember succinylcholine. Now, what is the mechanism of action? How does it work? I have told you already. Let me explain that. Now, this is the receptor, and we know that the receptor is NM. So NM is ion channel receptor. So whenever the succinylcholine comes and sit on the receptor, now who will enter? The ion will enter, that is sodium. So along with sodium, calcium also will enter inside. So what you see is, initially you see the muscle contraction. So what we see initially is muscle contraction, and that contraction is what we mean by the fasciculations. So initial fasciculations are seen. Initial fasciculations are seen. Now, what happens when the muscle is fasciculated and in contracting? It can exit the potassium out. So potassium can come out of the cells. So that can lead to hyperkalemia. So one of the complications of succinylcholine is it can increase the potassium. Now, what happens if you stimulate the receptor repeatedly? So I told you the nicotine receptor will undergo rapid desensitization. They are known to produce rapid desensitization. Yes, that means the receptor is no longer going to be excited. That means it is desensitized. So that will lead to flaccid paralysis. That will lead to flaccid paralysis. Now it will not recover. So this is the reason why it is called depolarizing skeletal muscle relaxant. One more problem is, since it is causing initial muscle contraction, when you have given succinylcholine, when the patient recovers back, he will complain of another problem, and that is muscle soreness. So muscle pain or muscle soreness is a problem. So he will complain of the muscle soreness. Okay. The next important aspect, when I understood the mechanism of action, where to use it? Where to use it? It is mainly used for intubation. The major use of this is intubation. Now, why do you prefer this only for intubation? Because it's very short acting. So when you are intubating, we want to relax the muscles of the neck, pharynx, so that it's easy to put the tube inside. Now, pharmacokinetically, succinylcholine is very short acting. It is very short acting. The onset of action is very fast. Within 1 to 1.5 minutes, the drug will start working. And how many hours it will work? Not hours. It's working only for minutes. So the duration of action is only 5 minutes. The point here is why it is very short acting. It is metabolized by an enzyme called pseudocholinesterase. So as soon as you give the drug, it is metabolized faster, so the action is terminated, so you can intubate, then no problem. So the succinylcholine is made inactive by the enzyme pseudocholinesterase within 5 minutes, and the drug will not work now, so patient will not have a problem. But there are certain people who don't have this enzyme, or the enzyme is different. Those people have a pharmacogenetic problem. So they will have the atypical pseudocholinesterase. So this is what we mean by the typical one. What everybody have is typical one. Now what if the person has atypical one? If they have atypical one, the succinylcholine is not metabolized faster, it takes longer. What happens if we are relaxing the muscles? The muscles, diaphragm muscles gets paralyzed. Patient cannot breathe. So if he is not breathing, it's called apnea, and the apnea gets prolonged. So what happens if they get prolonged? You have to put the patient on ventilator. So there is a problem with succinylcholine, particularly in certain individuals, that is called, if they have what enzyme? Atypical pseudocholinesterase. I explained that. So usually when we give succinylcholine for intubation, it will work for how many? 5 minutes. Suppose somebody have atypical, usually it works for 5 minutes if they have the typical one. If they have atypical one, it is not going to be metabolized, it will work longer. If they have atypical pseudocholinesterase. So if it is there, succinylcholine now becomes longer acting. In home, in these people, what happens if it is longer acting? The patient will develop succinylcholine induced apnea. Patient cannot breathe. So what to do now? If he is not breathing, you cannot leave him like that. So put the patient immediately on. What is the treatment for this? The treatment is put the patient on immediately ventilator. You have to put the patient on ventilator. Second, what you have to do is you have to give fresh frozen plasma. Sir, why should we give fresh frozen plasma? Because plasma contains pseudocholinesterase. But the plasma what you are giving, fresh frozen plasma, should be from non-deficient patient or a patient who has typical pseudocholinesterase. If you give one more plasma which has pseudo atypical one, there is no use. So you have to give a fresh frozen plasma which has the typical pseudocholinesterase. Or we have recently recombinant form of typical pseudocholinesterase that can be used. So recombinant form can be used. So this is the point. Sir, okay, we all agree with that, what you are told, correct. But how do I know my patient has this problem? हमें कैसे पता चलेगा कि problem है? So that's the reason before giving succinylcholine, you have to detect this problem. The problem is detected by Debbucane number. So Debbucane number is going to tell us. Now if the number of this is 80, that means normal. So normal is 80. If it is between 50 to 60, so the patient has heterozygous trait. If the number is between 20 to 30, he has the homozygous trait. Yes. So in them, don't use succinylcholine for intubation. So don't use in them if their number is low. So then what to use? Can we use mevacurium? Can I use mevacurium? No, because mevacurium is also metabolized by pseudocholinesterase. So don't use mevacurium also because it is also metabolized. Then what do you do in this patient? In this patient, if you want to do intubation, so what we can do is we can use rocuronium. Rocuronium can be used many times. You will get confused. And yeah, we can give mevacurium, again a shortest acting one. No, because mevacurium is also metabolized by typical pseudocholinesterase. If you give in this individual who have atypical one, again the problem is same, apnea. That's the point. So once I know the mechanism, once I know the uses, and now it is the time to understand the adverse effect. Now I told you it increases the potassium hyperkalemia, and you should never use it if the patient has muscle injury or nerve injury. Because if there is muscle or nerve injury, suppose he has come from a road traffic accident, so potassium would have been already released, and this will also increase the release. So that's the reason we should not use it. And it increases the pressures like intraocular pressure, it increases the intragastric pressure. So you should be very careful when you're using it. One more is when we use succinylcholine in a person who has defective renal receptor, what can happen? Yes, take a guess. There people can be prone for malignant hyperthermia. Malignant hyperthermia is again a risk, not in everyone. Certain individuals are prone for that. Okay, so we are done with the depolarizing skeletal muscle relaxant that is called succinylcholine. And mainly you have to remember the succinylcholine induced apnea, which is a pharmacogenetic condition. So let us move on to the next type of muscle relaxant. They are called non-depolarizing skeletal muscle relaxant. Non-depolarizing skeletal muscle relaxant. Now, I told you how do they work. Suppose this is the receptor. I'm just writing the receptor. The acetylcholine also tries to bind here. So, agonist for this receptor is acetylcholine. The receptor is NM. The antagonist for this receptor, let me take the example of D-tuberculin, is the antagonist. So, both of them are trying to bind to the same receptor. Acetylcholine is also trying, D-tuberculin is also trying. Who can take over? Whoever is more will take over. So if I give more D-tuberculin, that will block it. So that's why there is a competition. These are also called as competitive neuromuscular blockers. Now, how do you overcome this? How do you overcome this blockade? How do you overcome this antagonism? Yes, by increasing acetylcholine. Now, how do I increase acetylcholine? By inhibiting the enzyme cholinesterase. And who will do that job? That is done by two important drugs, neostigmine and one more drug, pyridostigmine. Neostigmine and pyridostigmine. So, suppose we already have given this muscle relaxant during anesthesia. The surgery is over. Patient is put to post-operative ward. Before that, we want the patient to be back with a muscle contraction. So what we do is at the end of anesthesia, we give neostigmine, pyridostigmine so that the muscle will come back to the action. So we will want to reverse it. So we use them at the end of the anesthesia. The name is neostigmine and pyridostigmine, which can reverse this. But in case of succinylcholine, these are not successful. Why? I told you, because it is a depolarizing skeletal muscle relaxant, and succinylcholine is very short acting, so it is going to be vanishing within 5 minutes. So no need of any reversal agent for that. Okay, so moving on to the drugs which are called the non-depolarizing or competitive skeletal muscle relaxant. Let us start now. So let me start with the drugs. Now in these, importantly, let us understand there are two categories of drugs depending on the chemistry. So isoquinone derivatives. Isoquinone derivatives. And one more is the steroidal derivatives. So we have two important aspects here, isoquinone derivatives and steroid derivatives. So what's the difference here? Now isoquinone derivative, we have a drug by the name D-tuberculin. The name is D-tuberculin. Now these D-tuberculin has one property, that is histamine release. So it can cause histamine release. Now because of that, it can decrease the BP. And second is it can cause ganglionic blockade. Now you may ask a question, why ganglionic blockade? Because ganglia contains NN type of receptor. So if it is blocking NM, there is a chance it can also block NN type. So ganglionic blockade. So because of this reason, it is not used commonly nowadays. One more drug is called metocurine. The name is called metocurine. And then we have a drug called atracurium. Atracurium after metabolism will give rise to a compound called lardosine. And lardosine is known to produce seizures. So they can ask you this question. Now what is the reason why atracurium can cause seizure is because of the metabolite lardosine. Now one more drug is called mivacurium. I think I have introduced this drug already. Now if you observe, all these drugs end with curium. Muracurium is metabolized by the enzyme pseudocholinesterase. So because of that, it is the shortest acting drug. So it is the shortest acting drug. What drug? Shortest acting non-depolarizing skeletal muscle relaxant. What is the shortest acting? depolarizing skeletal muscle relaxant is succinylcholine. That's it. Now, it is the shortest acting. Okay, I told you that. And it is mainly used in intubation process. Now, please understand these three drugs, what you have written, they can cause histamine release. So, all these three drugs, what you have written, they can cause histamine release, right? Now, moving on to the other drugs in the same category. What are the other drugs? We have the same atracurium, but here it is called cis atracurium. Now, this cis atracurium, the advantage is it will not release the ladocin, so no risk of seizure. Second drug is called doxacurium. It is called as the doxacurium. Doxacurium is the longest acting drug. It is the longest acting in this category. So the shortest acting is myocurium. Doxacurium is the longest acting. So it has the half-life around 2 hours. The name is doxacurium. And the last one, it is still an investigational drug. It has not come to the market. It is called gantacurium. And if it comes, that will become the shortest. But still it has not come, so we are not going to worry about that. Until that, the shortest acting is myocurium. And all these three have an advantage. They have no or least histamine release. No or least histamine release. That is the advantage. So recently they had asked a question, atracurium, will it release histamine? Yes. Cisatracurium, no. That is the difference. Now whenever we talk of these two drugs, the question pops out repeatedly. Atracurium and another drug similar to that is cisatracurium. Now these two drugs undergo a special type of metabolism, and that elimination is called Hoffman's elimination. It is called Hoffman's elimination. What happens here? In Hoffman's elimination, there is spontaneous molecular rearrangement of the drug. Spontaneous molecular rearrangement of the drug. So it's a chemistry, don't worry about that. Now, this drug clearance, that means to throw the drug out of the body, doesn't depend on the kidney function or liver function. So what is the question you are expecting? These two drugs are safe in a patient with renal failure or liver failure. So this is a repeatedly asked question in your exams. Which is safer? Yes. So that is about the isoquinone derivative, ditubercurin, metacurium, and all these drugs end with curium. We see the names curium. Except you have to remember ditubercurin and metacurium. They don't end like that. Now moving on to the steroidal one. So steroidal one, I'll write it below. The steroidal derivatives. Steroidal derivatives have the advantage no histamine release. No histamine release. So no decrease in DP. Now what is the drug here? The name of the drug is called pancuronium. Okay, I'll repeat here. What is the drug name? Steroid derivative, the name is called pancuronium. Now you can see here, curonium, it ends with curonium. There it was curium, here it is curonium. And pancuronium has vagal blocking property. Vagal blockade. Now what is vagus? It's a parasympathetic. So what happens when you block vagus? There is tachycardia. So the drug can cause tachycardia. Then similar to that, we have another curium that is called pipe curonium. So pipe curonium, then one more drug is called rapacuronium. Rapacuronium, the name itself is telling you rapid. So it has rapid onset of action. So one time it was preferred for intubation, but nowadays it is not used because it causes bronchoconstriction. So the problem what we faced by that is bronchoconstriction. Then what we are using is rocuronium. It is now used for intubation and it doesn't produce bronchospasm like that. Then we have vicuronium. So you can see everywhere it is curonium, 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 curonium. I told you when you want to reverse this muscle relaxation, we use neostigmine or predostigmine. Now, rocuronium and vicuronium, they can be reversed. We have a reversal agent for this. So the name of that is called Sugammadex. So that is the best one. It will reverse the muscle relaxation. The question asked is, sir, can I give neostigmine, predostigmine in rocuronium, vicuronium? You can give, but compared to neostigmine, the faster acting is Sugammadex. That's why it is preferred nowadays. Okay, only it is approved for Rho and V. Okay, so that is about the non-depolarizing skeletal muscle relaxant. So okay, so let us write the uses now. Uses of the peripheral skeletal muscle relaxant. Particularly, I am talking about the depolarizing and non-depolarizing skeletal muscle relaxant. So where to use it? Obviously, their use is in general anesthesia. Yes. Number 2, during intubation. Number 3, they are used in assisted ventilation. So if you are putting the patient on ventilator, the muscles of respiration should be relaxed. Suppose the patient is on ventilator, if these muscles are not relaxed, so he will have resistance. So it has to be relaxed. And it is also used in the convulsions and trauma due to. So there may be convulsion and trauma during ECT. ECT stands for electroconvulsive therapy. So when we give it, there is a chance that patient may have convulsion and trauma during shock therapy when you give a shock. And it is also used in severe cases of tetanus. So tetanus, you know that it's a muscle spasm condition, so there we can use it. And very rarely, these are also used for status epilepticus. Very rarely they are used. So these are the conditions where we use the muscle relaxants, peripheral skeletal muscle relaxant, but particularly remember the first 3 are very, very important. They are used in anesthesia, intubation and ventilation procedures. Yeah. So that is about muscle relaxant. Basically, you have to keep these things in your mind. Now you can relax the muscle, particularly for anesthesia and particularly for intubation, right? And when you're putting on the ventilator support. Now, there are 2 relaxant, peripheral and central. Central, they inhibit a polysynaptic reflex. They decrease the tone. Voluntary power is preserved. They can cause sedation. They are used in muscle spasms. So patient will be conscious. Patient will have normal voluntary movement. No problem. You can give it outside also, OPD also. You can take it to home also. No problem. Peripheral skeletal muscle relaxant, they act on neuromuscular junction. Number 1, botulinum toxin, decrease acetylcholine release. Number 2, dantrolene sodium, it acts directly on thyroid receptor, and that is a directly acting skeletal muscle relaxant. Drug of choice for malignant hyperthermia, drug of choice for neural malignant syndrome. The drugs which act on NM receptor are 2. Depolarizing is succinylcholine. Succinylcholine can cause apnea if they have atypical pseudocholine stress. How do you detect? By dibutyl number. And it can increase potassium, it can increase the intraocular pressure, intragastric pressure, and some individual it can cause malignant hyperthermia. Then coming to the non-depolarizing, so they are going to compete with acetylcholine. You can reverse it by using neostigmine, predostigmine. The isoquinol derivatives, they can cause histamine release like D-tuberculin, metacurine. Then we have mivacurium, right? And atracurium. They end with curium. Cisatracurium, doxacurium, and the new drug gantacurium, it's still in investigation. They don't release histamine so much. And atracurium, cisatracurium, they undergo Hoffman's elimination. So they are safe in renal and liver disease. No problem. Steroid derivatives, they end with curonium, rocuronium, vicuronium. They can be reversed with one more drug that is called sugammadex. And major use of these drugs are in anesthesia, intubation, and mechanical ventilation. So that is about skeletal muscle relaxants. Thank you all.